Good afternoon and welcome to Leveraging Data Center Infrastructure to Meet the Quadruple Aim, a Health Systems CIO Media Inc. production sponsored by Hewlett Packard Enterprise and Intel. Just a little housekeeping before we get started. My name's Anthony Guerra. I'm the Editor-in-Chief of Health Systems CIO, and I'll be your moderator today. We're hoping for your participation today. You could send your questions and comments in the Q&A box. We're also going to do a little poll later in the program. We hope you'll get engaged in that. Nice way to view the screen is click on the top center and get that into side-by-side mode. Then you can adjust the divider to get the slides and the video boxes how you like them, and you want it to say speaker view in the top right-hand corner. Just so you see how we're going to spend our time today, first we're going to have our panel discussion featuring my good friend Chuck Christian, VP of Technology and CTO with Franciscan Health, Jim Brady, Dr. Jim Brady, Interim VP, Information Security and Infrastructure and CISO with Fairview Health Services, and Ivers Apsite, Healthcare Practice Manager with Hewlett Packard Enterprise. Then we're going to have our Q&A. So let's jump right into the discussion. We've got lots to talk about. Chuck, why don't you start off? Can you give us an overview of your organization and your role?
Sure, absolutely happy to. Franciscan Health is a 13-hospital system that has facilities in Indianapolis all the way up to Chicago. We have about 400 physician practice and ancillary services locations scattered through Indiana and in the Chicago area, particularly south suburban Chicago, and up into very southern Michigan. We have about 2,000 inpatient beds, about 1,600 physicians. We're a great organization to work for, faith-based, Catholic with a big C organization. I'm very pleased to work here. I've been here for about 18 months now. They still let me show up for work remotely every day. And my role as Vice President of Technology and CTO is, if anything is broken, I own it. And so I've got a great team. As you can well imagine, the infrastructure that we support on a daily basis to make this organization work is quite complex. And we tested it greatly when we moved about 4,000 or 5,000 of our employees to remote work in 2 weeks. And so, like I said, got a great team. Very proud to be part of that.
Excellent, Chuck. Thank you. Jim?
Right. Thanks, Anthony. I'm really excited to be here. It's a great panel you've got, and so happy to be part of that. And it's an awesome topic, so I think we're going to have fun. So I'm currently the Interim VP of Infrastructure and Security and the Chief Information Security Officer at Fairview Health Systems. Very similar to what Chuck, the organization he's at. We also have 13 hospitals, about 100 plus clinics, 36 pharmacies. We have recently established a partnership with the University of Minnesota Medical School and the University of Minnesota Physician Group. So there's about 5,000 physicians there. So we have a great partnership going. So that partnership is called mHealth Fairview. So you'll see folks from my organization. Often they refer to either mHealth Fairview or Fairview Health Systems. And it's about 40,000 staff. It's about $8 billion organization covering the Twin Cities and Minnesota. Yeah, so that's a little bit about me and the role. And as I said, I've been on board since April, and I'm actually speaking from sunny Southern California, as I've been, the last 3 months, I've been doing the role 100% remote through Microsoft Teams.
It's amazing, right? Who would have thought a few years ago doing a role like that, 100% remote? It's amazing and kind of wonderful. Ivers.
Yes, hello, my name is Ivers Apsite. I am currently serving as a healthcare practice manager on the HP healthcare team. One of my primary responsibilities on the team is to not only interface with customers, but also serve as the HP Epic liaison how I earned that role is in my former role, I've actually worked in IT almost all my life, and the last third of it I've been spent in IT leadership in various healthcare roles. 9 of those years spent at a health system working in IT, and there we used Epic, and have lots of both actual healthcare industry experience from not only supporting healthcare, but as a consultant, and now working for HP as on the vendor side. So I'm looking forward to this conversation and be able to speak to it from both sides of the fence, if you will.
Excellent. Thank you, Ivers. All right, we're going to talk a lot about the quadruple aim today, low cost, high quality, and high patient and provider experience. It's going to be a theme in our discussion today. So how is the quadruple aim driving your decisions in your healthcare system? Jim, let's start with you.
All right. Well, obviously, everybody knows there's been a little thing called a pandemic that's upended healthcare. So there's a lot of, I think we've heard a lot about it. That's kind of the topic of the day. So one of the things we're focused on is as we look to come out of the pandemic, and hopefully we'll be coming out of it soon, is to come out of it as a materially different organization. So from the CEO, the board, all the way down, the discussion really is about how do we shift and pivot to address the needs of, we definitely want the highest quality at the lowest possible cost. And so how do we as an organization, change so that we can reduce our costs, so we can do things more efficiently. So, I think we know that process improvement is something. Fairview Health Systems is a strong lean shop, so there's quite a bit of process improvement and those types of things that have been going on. But really, to transform it, to do that 180 shift, to do something really significant, we really do need something that's transformative. And I think we all know that, those of us on this call here and listening, we know that technology does have the potential to make those, amazing transformative things. So we're looking at, really addressing costs through consumerism, through, we've recently went from zero. I've heard a lot of stats on different CIOs, talk about how they went from, a small number to a large number of video visits, but we went from zero video visits to 60,000 a month. So it's kind of an interesting stat. A lot of that is telephone calling. Some of that it's because we need to train our providers and things in order to use video, but we have several video solutions in place. So we're looking at automation, we're looking at strategic sourcing, we're looking at our infrastructure. How can, there's a lot of opportunity. And one thing I wanted to mention at the beginning, and I'll kind of end with this, is Fairview Health System actually is merged with Health East Health System, which is a pretty large health system, back in 2017. And true to the holding company model of the organization, we didn't necessarily change the infrastructure. We didn't bring everybody into a common standard. And so now we have a great opportunity to look at our cost structure and say, how can we standardize, how can we systemize, and so I think, and then look towards platforms. So I think there's a lot that technology can do. The business definitely is looking to us for leadership and guidance as they move forward. So I think we got some wonderful opportunities at Fairview. So
all right.
Thank you.
All right, very good. So interesting. You want to come out materially different than you went in, sort of that no crisis should go to waste type thing, right? Take advantage of
Absolutely.
the opportunity for change. Chuck?
Well, I think everything that Jim said, and I'll add a little bit to it. I think one of the things that when I joined the organization, what we're trying to do is get to a very high resilient infrastructure. In organizations our size, it's like I said, the infrastructure is very complex. We just finished redesigning our network to create some additional redundancy and resiliency. If you look at most healthcare organizations, they're kind of working their way out of the data center business and moving more into software as a service and other, potentially platform and, cloud-based services. And so if you don't have a network that can heal itself, you're going to be in trouble pretty quick. And so we've been working in that direction. And then the other thing that, Anthony, that I've been in healthcare for now almost 5 decades. And I grew up in healthcare on the clinical side. So I have a passion and understand that the technology is just a tool. A lot of the things that we've been working with over the course of years to automate healthcare, we've basically done exactly the wrong thing, in my humble opinion. We've automated paper-based processes without looking for the appropriate solutions that will make them more efficient. And so, it's the old adage is, if you really want to screw things up, let a computer do it. And so I think we're learning that now, and we're working to remove some of the burden that we've added to our clinical staff, physicians, nurses, pharmacists, you name it, because we're now starting to, we have enough data that we can use to leverage that. And so I think that's one of the key points is we can automate a lot of things. And we had this conversation at our senior leadership group this morning, as a matter of fact, is we need to leverage the technology and the tools to help us improve our organizations. We learned some valuable lessons about what we're capable of when we dropped into crisis. As I mentioned, we moved about 4,000 to 5,000 folks. Our entire IT department, in the building I'm in, we house about 356 folks, including myself. We all went remote. That building has stood empty now for many months, and we moved all of our billing offices, our coders, home without a great deal of issue, and keeping in mind that we're totally dependent upon and at the mercy of everybody's local ISP, just like I am with mine. So we need to leverage that. We also learned a lot about how our physicians, how creative and innovative our medical staff can be when faced with issues about taking care of our patients, and the dedication they have of making sure they want to take care of the patients, particularly that are most vulnerable, have comorbidities and they have disease states that need to be taken care of on a more regular basis. And so, and how they're taking care of those patients on the inpatient basis too. And so, as you said before I started my conversation, was we can't let a good crisis go to waste. And so there's been many things we're going to carry forward to help move us into this realm of where we're going to be accepting full risk for our patient populations. And using the technology to do that. And so if we can't move into that realm of better outcomes and being reimbursed for how well we take care of our patient populations, because for 10 years we've been saying it's coming. Well, I think it's here, and we better be prepared for it. And since I'm getting a little older now, is that I want that healthcare system to be able to provide the excellent healthcare, but at a price point that that we can tolerate. So we're going to have to use technology to get us there.
Excellent, Chuck. Thank you very much. Ivers?
Well, Quadruple AIM has been, I think, a stalwart for healthcare, and we on our team actually use a quote from the advisory board that reports that a 10% increase in patient loyalty can drive up to $22 million in revenue for the average health system. And that actually brings an interesting observation, because patient loyalty, what drives patient loyalty? And that realistically comes down to the type of care that they give. Well, who's the main caregiver at a health system? Well, it's the clinicians, it's the physicians, it's the nurses, it's anyone else that engages with the physician. IT doesn't really touch the patient. Okay, so how does that all tie together? Well, the health system then really serves two customers. and the patients are one, but really it's the physicians, the clinical staff that are delivering that care. So when I was working at a health system, we adopted a model, where I exist to serve those who are providing or receiving life-affecting health care. So our whole effort started to focus on what are we doing for those who are providing health care. We were, what kind of drove that home to me is we were one of the first health systems back in 2007 where we wrote our own VDI solution. We did a virtual desktop before anyone even knew what a virtual desktop was. And I was actually amazed at the impact it made on physicians, because back then, how long did it take you to boot up a PC? 2 minutes, 3 minutes? People would shut it down. I mean, back then, many times you would see a physician duck in on a nurse's credentials to quickly do some documentation in what was, an EHR back there, back then. And it was just all wrong, but that is what occurred because technology was clumsy. And when we introduced a technology that could literally help you resume where you left off in less than 10 seconds, it was a game changer as far as physician satisfaction. And what was really cool is we did some analysis, and that parlayed into improved throughput. I mean, we actually had better efficiencies on our workflows, and thus reporting into quicker turnarounds. I mean, less the length of stay. I mean, that all suddenly added up into a improved bottom line. And we kind of started playing that back into how all that impacted the quadruple aim. We had, just overall by improving workflows, by faster response time workflow, not only do we have satisfied patients, satisfied physicians and nurses administering the care, but also we had lower costs. So all this started really making sense. So we kind of adopted the quadruple aim as our speaking to. Matter of fact, one of the CIOs that I know often says, if you can't speak to the quadruple aim, don't even bother talking to us. So that's kind of how I wrap up my whole philosophy of being able to, speak to those in decision-making roles is, can we speak to, and can you speak to me in quadruple aim vernacular? So it helps improve the healthcare that we're delivering. And that, I think, is every one of our goals is, we exist yet to make sure everything is working, and we operationally make the health system sound financially, but we actually all really care about how we're impacting those providing or receiving life-affecting healthcare.
Great. So it sounds like your opinion, it could be extremely useful for setting strategy and operations and all that type of thing. So very good. Next question. Typically, all four aims are recognized as equally important. Does one of them carry more importance or significance to you or your health system, and why? Chuck, let's start with you.
Well, I mean, I agree they're all equally important, but I think that, one or two beget all the other ones. I mean, at the end of the day, the patient experience is, for me, the most primary focus. Having come from a clinical background, our health systems, that's what we do. And I remind everybody, I've done it for many years, is, our primary role is taking care of patients. And, we need to, as we're moving from sick care to well care into health care, is taking care of the health of of the individual, and that organization exists to do that. I mean, if you look at the way healthcare has transformed, or that metamorphosis of healthcare over the last many decades, we've transitioned a lot of inpatient things to outpatient. Today, you can go have a cholecystectomy, which is having your gallbladder removed, as an outpatient procedure. I can remember decades ago that you were going to be in the hospital for at least 8 days, and you were going to take about 8 weeks to recover. And
Wow.
so the technology has allowed us to make a lot of changes in the way that we provide intervention in healthcare. I'm a recipient of a stent in my right posterior artery after an event that should have killed me 24 years ago. And so I'm kind of living proof that technology, that they didn't have to crack my chest in order to do that. They did it through a catheter. That's the thing that I think that everybody's looking for. It's not really a magic bullet, but how do we impact how we care for our patients? No different than when we couldn't bring patients in our physician offices to provide the well care and the check-in care that they needed to have. We've rapidly stood up. I think Jim said they went to 80,000 visits a month. We were not too far behind on how quickly we ramped that up. And provide great care, not only through virtual visits, just on the phone, just to check in and do the things that we ought to be doing. So for me, the patient care, and along with that, we have to also impact the providers as well, because it's kind of like the joke of the good old boys with the chainsaw. You can cut wood with it, but it works a whole lot better if you crank it. And so we don't want to burden the physicians with technology that's going to get in their way of taking care of their patients, or cause them to take shortcuts in order to get their work done, because we keep adding to the workloads and expecting more, and it's just not there. And so the time has to come from somewhere. So those two are, and I think that once we get those two, the other two will follow.
Very good, Jim.
Yeah, Chuck, so I'm a city boy, so I totally, I intellectually get what you're saying about cranking the crane chain, but I mean the chainsaw, but yeah, so I'm with you on the patient experience, because at the end of the day, why are companies like, why is Amazon so successful? It's because they're delivering, high value for a very low cost. And so I think, if you have the greatest quality, but people can't access it, then that's a problem. So I think access to care, having it affordable, and then, as to my earlier comments about, looking internally at the organization, healthcare systems, we have lots of opportunities to cut cost, to extract out cost, and then to use technology to find new business and to do things more innovatively, and to accelerate our growth. So I think it's looking, on one hand, being competitive, like we're in the Twin Cities, so there's an opportunity for our organization to be the leader in virtual care and telehealth. So even though we weren't doing a whole bunch of it before, I think that we have to look at opportunities for growth. How do we stay in business? How do we thrive? And so those are things that, I think we're looking at, and we can pass those on to our patients and those that are part of the health plans. So I think those are things that, we're really taking a hard look at, and I think it's important. I know prior to COVID, there was lots of discussion at different organizations I've been at with physician burnout, and making sure that the EHR is not, as Chuck said, just a paper-based rewrite to digital, and it's remembering the providers, that they're the ones laying their lives down doing the care. And so I haven't really heard a whole bunch of it in the last couple of months, because I think we've been so heads down on standing up surge capacity and leaning in. And so but I really do think it all focuses in on making sure that those that need the care can get quick access to it. And so I think that probably falls under the patient experience. But upholding that are the other quadruple aim components that we need to have in place. And I think organizations are going to have to look at, how can they sustain themselves in this new era that we're about to enter into, which I'm not sure we even know what it's going to look like fully. But I know that if we're running lean and we're efficient, we're using technology, and we're not afraid to fail, you got to take some risk moving out. Then I think that we'll start seeing health systems finding themselves moving forward. And we already know, and there was definitely some discussion about this in a lot of the circles that I had been a part of, about the non-traditional healthcare entities that are kind of coming into healthcare and taking the, what essentially the non-acute care business and offering access, low cost, convenience. So I think that, as we get our platforms together and develop some of those things, make them available, definitely focus on mobile. That's where a lot of folks are at this point. They don't walk around carrying laptops and PCs. They're basically mobile, and agile development, having the ability to quickly spin up and spin down services. I think that's important. But it's all wrapped around the patient experience, I believe, and where the patient is at the center. But we do have to remember that as Ivor said, we do have to take care of those that are helping make this happen. That's our providers, our doctors, and our nurses. So yeah, all four important, but I would go with the patient experience.
Very good, Ivers.
Interesting. I hold a bit of a different thought pattern, where, as I said earlier, there's two customers. We have the patient. So everything that Jim and Chuck just echoed, I fully am in line with. Yet, as Jim just alluded to, who drives patient satisfaction? And that isn't without excellent physician and clinician care. And, when you look at the history, it was initially triple aim, then went to quadruple aim. Well, what was added? The physician, the clinician experience. And I believe that was an evolution of the aims, if you will. And that was added because, what happened at that time? Well, we went from a paper-based solution to a electronic-based solution. And quickly we ran into the whole concept of, dependence on technology, dependence on, electronic workflows, the dependence on the people to not be knowledgeable of using the technology at the same time while delivering care. And there's a lot of physician sentiment, if you will, is the EHR really a beneficial environment or not to actual patient care? And that's a very religious discussion, not one for this topic. But the net is we were experiencing physician burnout, and people just not willing to use the technology, or poorly implemented technology solutions that really impacted the physician and clinician experience. So I would say that physician experience is not, if not equal to patient care, it's maybe even a bit higher, and only because, you want your physicians to be able to dispense care, to do what the patient needs them to do at that point. And that can flow throughout the whole, patient experience throughout the health system. And I'm really, therefore, more probably focused, if I've been focused on something, it's at the physician experience. Again, I'll relate to VDI experience. Whenever we tested our VDI experience, if it impacted the physician by 2 more clicks, and you multiply the 2 more clicks across a bunch of physicians, that could cause a negative experience. And physicians aren't happy about it. Guess what? Sometimes it flows out into their care patterns and care practices, and they'll either stop or create workarounds. So we're almost maniacally focused on very hyper efficient workflows. And what was even interesting back then, we're very eager in even getting physicians involved in the EHR so they could actually customize and improve on the workflows themselves to improve the patient care. So all of these kind of things added up to an improved physician experience, resulting in better patient experiences, and even impacting outcomes, which all of us get measured on. As you know, the CMS loves that metric, and we have a hard time speaking to that. But I believe physician and clinician experience is the root core focus of all of that.
So Anthony, let me add to what Ivers and Jim and I have said is, and one thing that, we have to go back in the Wayback Machine in about 10 or 11 years. And why are we here? It's not because the industry was moving forward, we were, but we're moving much slower than the country wanted us to go. So we had this little thing called high tech that was part of the Reinvestment Act in 2009 that generated a significant amount of funding in order for us to move healthcare into the electronic age. A lot of us took advantage of that. However, it came with strings attached. In the beginning, there was a carrot that allowed you to gather the funds in order to pay for a portion, not all, of the technology that we had to deploy. And then there came the stick. If you didn't do it or weren't using this appropriately, I'm sorry, that was my wife letting the dog in. And so and so we were very quickly required to not only automate, but also show that we were using those investments appropriately. And so there was a lot of things that we had to, functionality that we had to put immediately into EMRs to capture the data that we had to report back to the federal government so we wouldn't be penalized. Because we weren't meaningful users, which is now, it's transitioned over to interoperability. And the other thing is that we tried to very desperately to make solutions exchange data that were never ever designed to exchange data. We're much better at it today, further on down the line. But I just want to mention that where we are today, a lot of it is unintended consequences of the rules and legislation that came out of Washington, D.C. about now 12 or 13 years ago, before it was finalized in 2009.
Jim, any thoughts on that?
No, I mean, I pretty much agree with Chuck on that, so nothing additional to add.
All right, very good. Next question. This is an interesting question. What metrics do you expect your IT teams to provide that confirm or deny adherence to or improvement upon achieving the 4 aims? So if that's your goal, if you're looking at achieving those aims, how are you measuring whether or not you're moving in the right direction? Jim?
Yeah, so for that one, I think there's some work that we need to do just on metrics and reporting overall as an organization. So I think we'll be looking into that. One thing I did want to comment on is, some of what we've seen in COVID is where, as Chuck mentioned, we went rapidly to a remote workforce. So pretty much all of ours that are not needed in the clinical spaces are working remotely. So it really did change the expectation on IT. Like if IT can, transform that quickly, do something that we've been trying to do for, months or years, and we can do it in a matter of weeks, then it kind of changes the expectation. And so reporting on that and having metrics and understanding it, I think is critical. And so we need to make sure we have the right systems in place to even get the metrics. So in my case, I'm looking to see what we have kind of too many monitoring systems at this point. So we need to kind of consolidate down. So looking at how can we get the statistics and how can we get those metrics and report them out that the business would understand what those are and their business trends, relatable types of things.
Chuck? Sorry. Go ahead,
yeah,
Jim.
The other thing I was going to mention too is we had a lot of projects in the pipeline, pre-COVID, and then now that we're kind of in this state, to get that ability to quickly do things, we had to stop doing a lot of things. So a lot of our reporting especially on a project-based perspective has been paused, but because we focused on just a few things. So it shows if, it's we're kind of looking at what do we need to, and maybe this will be related to one of the questions that we're going to talk about further on in our discussion. But what is our priority? How do we keep that focus? How do we report on that focus? And then so we can keep that same speed and agility. And we're already seeing a little bit of creep now that we've started to add in some of the, like we've had projects continuing on during COVID that were kind of coming through IT governance. But for the most part, they have been paused, but some have been maintained. But now that we're kind of opening things up a little bit, we're seeing that that a little bit of the how we're not able to do things quite as fast because now we got more pots on the stove. So I think it's a lot of it is we want to identify what is priority and then translate that in business terms and clinical terms, and then make sure we get the business buy-in and they're aware of kind of what we're doing so that we can be meeting expectations or ideally exceeding expectations. So
very good, Chuck.
Well, I would agree with everything that Jim said. It's kind of interesting is that IT did very quickly we turned our stuff inside out to transform the organization, to do a bunch of virtual and remote stuff. And so it's kind of funny now, it's just like Jim said, to say, okay, if y'all can do that quick, so let's get some of this other stuff. And so let's add to your plate. And I reminded the team, I have a favorite saying. I went to the Disney Institute years ago. It's a favorite saying of mine that Walt Disney said, Walt Disney it's not magic that makes it work, but it's the work that makes it look like magic. And so it's the appropriate planning and all the due diligence and all the prep work that we have to put in order when we flip the switch on something that it works and you get the wow factor. Now, granted, true, we didn't have a lot of time to do a lot of planning and stuff as COVID hit, because we just didn't, and we ramped up. So, to get back to your the question is, that's one of the challenges that we're looking at right now. There is just a bucket load of, and y'all can tell I'm a demo country boy from Alabama. So there's a bucket load of things that we could monitor, but why should we? So we need to identify the things that, in areas that we need to improve upon, because this is no different than the Joint Commission accreditation and some of the other standards and monitoring that we've done in healthcare for years. There's a whole lot of stuff that we can monitor, but if it's not around the areas that you can improve upon, and you don't have a good plan, then you're just gathering data. And I think that was some of the stuff early on in some of the quality measures and stuff. We were measuring a whole lot of stuff, but it didn't really make any difference. We weren't moving the dial because we were gathering data. And so we need to identify those things that can show improvement, and those are the more difficult things. So I've challenged my leadership team I gave them I salted the list a little bit. Here's some things I'm thinking about. I'm working with my architects and my technical leads. Is what is it that we really need to monitor in order to find areas that we need to improve? And so one of my guys found an ISO model that we're looking at. So it's yet to be determined, but we've been monitoring a whole lot of stuff for a long time, but it's just kind of there. We have a dashboard, and it's kind of okay. It's cute. But what do we do with it? So I want something that's actionable that will point us in a direction. And the thing about it is, it's going to make us nervous, because the things that we're going to report on, we're not doing really good on. And so we need to use those reporting tools in order to do better.
Right, but you don't want to be spinning up metrics on things and go, we really need to improve there, but we have no time or resources to do it. So let's not worry.
Well, it's kind of like when I was growing up, when I did something wrong, which was a lot. My mama made me go out and cut my own hickory that I got whipped with, and so I don't want to do that with my monitoring. But unfortunately, sometimes we continue to go out and cut our own stick that somebody's going to beat us with. So.
Very good. Ivers, your thoughts?
Well, this is this one I've actually been living in for quite a few years now. On the vendor side, I really live in it, but I like to boil it down to what matters most, okay? And I'm gonna use my old CIO's, my former CIO's just metric. Whatever you put in, it better be snappy. Okay, well, define snappy. What is a snappy environment? Okay, how do you make Epic work snappy? Okay, and you start diving. Well, first of all, physicians or clinicians, you got to be able to get at it. So it's got to be always available. Okay, they always have to have that vehicle that they use to access their workflow, whether it's an Epic or some other tertiary app, available, and it's got to flow smoothly. So if you just get the access to a highly available application available always, you've made a major achievement. So that's a key metric that we focused on. Second of all is how efficient and how clicky, how invasive, if you will, is that. If that invasiveness required a couple of additional clicks, did it add to patient care? Did it benefit patient care? Did it make it faster? It might inconvenience the physician or clinician, but it improved patient care by a significant bit. That was a value that was important. If it decreased, just length of time to do something, that was valued. That had to be researched. So it's those kind of things that, again, we spent a lot of time in what impacted patient care, and that was often from the. So those are the kind of metrics that we were almost maniacally focused on, and from my discussions, many still are. So I kind of, back to you guys is, from now that you guys are actually involved in that, what is it that, like, from the either patient experience or physician experience, what's one or two most things that really your physicians are clamoring for right now? And that might most likely speak to the quadruple aim somehow, I bet.
Jim, you want to take that?
Yeah, well, I know as I mentioned, we've surged ahead into video visits, and so we've got a couple of different solutions. We've settled on a primary one for physician to patient, but we have been having some issues with connectivity, and it's kind of a cloud-based hosted option. So I think everybody jumping in and using that company has caused, I think they're having to kind of get their back-end infrastructure together. But the providers do want to be able to do what they do and focus on care and not have to worry about technology and not working in too many clicks and too many logins. And so we're using the tap in, where you tap in with your badge. So I think it's just being able to present technology mobile, where they can go from exam room to exam room, on a tablet or something like that. And having them, I think maybe Chuck might have mentioned that earlier, having them participate in the deployment of the new technology. So the CMIOs and the CNIOs, and engaging them. My experience is when that's been done, they're part of the team that's rolling out this, kind of like this new delivery. Then it's a much more like, the problems don't get them upset to the point where they're like pointing the finger at IT. It's because they're part of the team. So I think having technology that works. I think shifting and untethering from the keyboard, where right now we have providers that just, no matter how fast you can type, there's just so many things about that we need to shift more towards voice. So I think there's a lot of work going on with our technology vendors on intelligent voice and interpretation, and getting that correlated, and artificial intelligence and machine learning and hooks to the large vast knowledge base that can help them make evidence-based decisions. So I think that's I think that's something that's they're looking for. And then just a bit on something simple as communication. I've been in many organizations. They've struggled really. How do doctors talk with each other? Through secure texting, but then they're not necessarily wanting all the nurses to talk with them, so the nurses can't be on that platform. And then how do the nurses communicate? and then the pharmacists, how do we get information? We've got overhead paging going on. We've got these little black things that are on their belt called pagers that none of the millennials, they come into the exam room and they say, Doc, hey, I see all this high-tech stuff around here, but what's that little black thing on your belt, or that you have there? So it's called a pager. We use those in healthcare. So I think there's a lot of things we're dragging along technology-wise, and so I think we're getting there. I think there's, you mentioned, Ivers, about VDI and some of the problems with latency with that. Just having that experience where it's, you can get to where you need to get to quickly and do your job. And so I think we're moving in that direction. We're getting there, and hopefully maybe I'll get a chance to ask you a question, hint about 5G at some point in this conversation. But there's lots of things. Although in blockchain, there's a ton of things that are there, but they're not quite ready to come out of the oven yet. But they're we're looking at it. So, but they're all centered around delivering seamless access and care to the patient, and then the providers being able to have what they need. And equipping our nurses. There's the average hospital room has at least 5 medical devices in it, but ICU has up to 20. Maybe now with COVID, we're up to like 30. So it's a very complicated system, and we haven't talked a lot about data. We need to that data where we can do predictive analytics and predict people that are about to code blue. Those are things that patients really want. I mean, they're looking for that. The physicians and the clinicians, they are also. And so it's a lot of us, we just have to all come together and work and continue to drive forward on these these areas.
Chuck, did you want to answer Ivor's question?
Well, if Ivers will repeat the question, I'd be happy to, because I've forgotten what it is.
Basically, if regarding the lines of metrics, what's one of the big things that if the physician community right now is really clamoring for or driving you for improving their experience or their satisfaction?
They need less technology in their life. We need to make it smarter. One of the things, and Anthony knows that I work for one of the most successful health information exchanges. I've had the pleasure of running technology there for 4 years, been involved with it for, I guess, the last 15. Is there, in the state of Indiana, we now have one health information exchange, and how do we leverage that knowledge base in order to make the information available? So, because one of the things in talking to physicians that's always stuck with me is they said, don't tell me what I know, tell me what I don't know that I should know. And so when I was there, we did some development work with IU Health and Cerner to put together a Firebase application that would present information readily about a patient's chief complaint. That you ask most ER physicians, if you have a patient that walks in the door with chest pain, what are you going to be looking for? Well, they gave us 5 or 6 things they always look for, and so we were able to present that information to them almost instantaneously from wherever in the health system, multiple health systems that fed data into the exchange. And so I think for me is how do we innovate with the physicians to make the system smarter so we can enhance their ability to make the right choices, because I've got a lot of friends that are physicians, many longtime friends which are now retired, of trying to understand, I have a good friend who's retired as OBGYN doc that actually delivered my number 2 and number 3 daughter. Every evening that he would sit down for several hours and read. He would be able to get through maybe 10 or 15 articles out of his medical journals. And one evening he shared with me that he just can't keep up. Now, keep in mind, this was 30 some odd years ago. Because of the knowledge that is pouring out. He said if he spent 8 hours a day reading and trying to keep up with just on his specialty, it would take him forever to keep up because the information is coming out. And so I'm not sure how we expect these folks who are very busy, who have very limited time, how do we expect them to keep up? So we need to figure out ways to, to enhance their knowledge base and give them access to additional information. That's kind of a personal challenge for me. hadn't found it yet, but we'll continue to partner with the physicians to see if we can crack that nut.
All right. Jim, I want to give you a chance to ask your question. I believe you want to throw something in front of Ivers, but maybe also Chuck. Go ahead.
Yeah, well, I've got a question for Chuck, being the sage, experienced,
He is. It's true. It's true.
IT leader that's been in our community in the CIO community and just in healthcare for so long. So thank you for all the work you've done, Chuck.
Thank you.
So maybe I'll throw both questions up to Ivers. So I did a little bit of research that HP is kind of involved in the Open Distributed Infrastructure Management Initiative, I guess, and so I believe it's related to 5G. So my question just real simply is, when do you think it's going to be operationalized 5G? That's kind of question for you.
Ivers, you answer, then I'll give you my 2 cents.
Okay.
Well, and then let me just say this real quick: is I've still got stuff like DAS projects and things that are heavy dollars, and I'm just wondering, is there a better way to do this? In other words, putting in-building cellular connectivity, because if you want to get physicians off of using their iPhone for texting, you got to provide ubiquitous Wi-Fi, and then you need that cellular. Anyway, so there's definitely applications that we're looking for in healthcare to do things a little bit differently and less costly. So go ahead, Ivers.
Boy, I tell you, that's a very hot topic. 5G, in my opinion, is just part of the solution. It's looking like it will be the next generation of what I call the last mile connectivity. You need that consistent, reliable ability to connect to something. 5G really looks like it'll offer that. And the beautiful thing about that is up until now, we've always had to provide that transition point. How do you come in from being remote, if you will, and remote can be mobile, could be anywhere, and then come into the health system and then resume operations quickly, or better yet, maintain operations. 5G, I think, offers that ability to seamlessly connect externally and resume or continue work internally, and the same if you're internally, to leave premises and continue working without interruption. Now, that's how it's supposed to work. Yeah, HP and others were working on implementing that, but it isn't just 5G. I mean, so great you implement 5G. You also need then the middlewares, if you will, the application virtualization, the ability to present the application in a way that also behaves seamlessly. So if you access an application through a mobile device, and behind the scenes, as you know, you can have layers of technology supporting that. But when you when you're on a connection such as 5G, it looks like we'll be able to sustain that workflow. So the true litmus test, in my opinion, will be if we implement 5G along with the application presentation in sustainable way, can the physician be dictating, Chuck, as you said, take hands off keyboard, can the physician be dictating notes while leaving the premises and walking to their car to take off for their son's soccer game, and do it in a way that doesn't interrupt? I think that's the ultimate promise of 5G, and I hope that answered the question the way you're expecting, Jim.
Yeah, thank you.
So let me add on top of what Ivers said. Last week we have an organization downtown that's a nonprofit that's working with Verizon and AT&T. And it's basically a 5G innovation center that they're standing up downtown. So I went and my network architect and I went down. We're entering into a joint venture with an orthopedic group, very large orthopedic group here in Indianapolis, and looking at the technology because they want to future-proof their building. And Jim, I'll share with you. And this is going to be a disappointment to you, just like it was to me, because in talking to the folks that really know what they're talking about, and talking about millimeter wave technology, it doesn't penetrate very well. They have 1,200 square foot resource center they're building out, and they had to put in 2 different 5G antenna systems, Emerson antenna systems, in order to cover that entire space. And so I asked the question, so are you telling me I'm going to have to put a distributive antenna system into these buildings in order to leverage and be able to capture the 5G? And they said yes. And so the thing that worried me about that is I already have one DAS system that we put in one of our facilities 10 years ago that's obsolete. And so am I going to be spending, you know, as you mentioned, an expensive amount of money to put in another system that may be obsolete in the not too far distant future? So I think there's still lots that you and I and others can learn, but the thing about it is that I do believe that this technology offers a lot to be desired. But one of the things that bothered me a little bit when I was down talking to the folks looking at their space is they started talking about exposure to RF energy, and there are levels that they have to test for to make sure that you're going to be able to stay in that area with close enough to those antennas to do some of the stuff. And so there are things that we don't know yet. And so these are things the innovation centers like this one in downtown Indianapolis and others are going to help us ferret out. And so, you know, you can listen to, everybody's going to tell you that 5G is the next thing since, you know, the best thing since sliced bread. If everything goes perfectly, I think it is, but I'm enough cynic and pragmatist or I guess you can call me a cynical pragmatist because I've been around a long time, and I've had more vendors blow smoke up my shoes than anybody else around, that I want to make sure that and I'm bold enough to ask the questions and poke around a little bit on it. So.
Yeah, well, I would call you a realist. So.
Oh, well,
yeah,
thank you very much. Thanks. I appreciate that. So.
Right.
Yeah, we appreciate you referencing your shoes in that example.
Yeah.
Very much.
You're very welcome.
It's a family program, so
exactly,
thank you.
Exactly.
Yeah,
Right.
that's right. All right, listen, we could go on, but alas, we can't. So we're going to wrap it there. Regarding continuing education, you could use the final slide in this deck. You'll get an email when the on-demand recording of this event is ready to go. If you want to sponsor one of our events, you can reach out to Nancy from our team, and you can go to our website to register for upcoming panels. With that, I want to thank, what a great panel, very good time. I want to thank Chuck Christian, Jim Brady, and Ivers AppSite. And I want to thank Hewlett Packard Enterprise and Intel for sponsoring this event, making this discussion possible. And I want to thank you, our attendees. With that, everybody have a wonderful day. Thank you.